Thank you, Elizabeth. Good evening and welcome to the J.J. Cohen Mini Med School, brought to you by Colorado Area Health Education Center. Today starts the first session of the fall semester of the J.J. Cohen Mini Med School. Since 1989, Mini Med School at the CU School of Medicine has educated and thrilled audiences of all ages and interests throughout Colorado and beyond, with presentations by renowned doctors in the field on topics ranging from chronic medical conditions to current and emerging medicine. Today, we have the fortune of having amongst us Dr. Dan Bessesen, who will be presenting this evening's session. Dr. Bessesen is an MD and a professor of medicine in the Division of Endocrinology, Metabolism, and Diabetes in the School of Medicine here at the University of Colorado Anschutz Medical Campus. He is also the director of the Anschutz Health and Wellness Center on our campus and also the Anschutz Foundation Endowed Chair in Health and Wellness. Dr. Bessesen has conducted research on body weight regulation, dietary fat metabolism, and the clinical problem of obesity over 30 years. He's the immediate past president of the Obesity Society. Ladies and gentlemen, please allow me to welcome Dr. Dan Bessesen to today's session.
Well, thanks everybody for coming out tonight. Hello to everybody in the room, and those of you who are at home all over the state, I want to say hello to you. And be sure to put your questions in as we go here. Thanks for being here to think about obesity with me. Obesity is something people sometimes are uncomfortable talking about, but I think we really now see obesity as a disease of body weight regulation. Just like diabetes is a problem of glucose regulation or hypertension is a problem of blood pressure regulation. I hope to convince you that weight is a regulated parameter, just like those other parameters, even though we all have this subjective sense that we choose what we eat and we choose what we do. There's very strong biology under this. So I'm going to spend a little time on that biology and the epidemiology, and then we'll spend some time talking about treatment. So in terms of prevalence, there's different sources of data. This is the National Health and Nutrition Examination Survey. And so this is directly measured weights and heights in people all over the country. And what this is from 2000 up till 2018, which was sort of the most recent data. Actually, just on my way over here, I saw that there was new data just released today from the CDC that shows that this trend of increasing prevalence of obesity continues up until 2022. So this is obesity in this upper part, and severe obesity defined as a BMI greater than 40. So here, obesity in different groups. Some groups have more, some groups have less. This is in men. Regular obesity and severe obesity. Here's the numbers for women. And what you can see is between 2000 and 2018, there's just a chronic upward trend, both in obesity, defined as a BMI over 30, or severe obesity, defined as a BMI over 40. Such that in 2000, the prevalence of obesity, men with a BMI over 30, was 27%. And by 2018, it was 43%. And severe obesity, BMI over 40, went from 3% to 6.9% in men. And here are the numbers for women, 33 to 41%, and severe obesity, 6% to 11%. 1 in 10 adult women have a BMI over 40. So if this was an infectious disease, you might be worried that this is a problem for the health of our country. Let me just start by saying, again, I think there's this idea that maybe people weigh a lot because they made poor choices in their life or something like that. And let me just try to convince you that weight is a regulated phenomenon. We could spend a whole hour on this. This is a rat study, and the advantage of rat studies, you can control everything. You can control their diet, you can put them in a certain environment. And if you put a rat in an environment that has easy access to food and not a lot of exercise, kind of like the world we live in. This is a rat's life. This is the rat's weight. What you see is that the rats will gradually gain weight through the whole course of their life. You can take a rat and overfeed it or underfeed it. So take this rat, put a tube in its stomach and give it more food than it needs, it'll gain weight. But when you stop that overfeeding, the rat's weight goes back, not to where it was, but to where it would have been. Isn't that wild? And if you take the rat and put it on a diet, it'll lose weight. And then if you let the animal eat whatever it wants to, the weight goes back not to where it was, but to where it would have been. So I think this describes the natural physiology of weight, is it's a trajectory of gradual weight gain. People use terms like set points and things like that, which implies that weight is defended at a particular level for everyone's life. But I won't show you all the human data that supports this, but most of us gradually gain weight through our whole life, a couple of pounds per year. Women go through menopause, they tend to gain a little bit of weight at that time. There are people who tend to gain more weight, and that can be because they're genetically predisposed to weight gain, or because they're in an environment that particularly fosters weight gain. You can do this with an animal. You can put an animal, feed it nothing but a high-fat diet, it'll tend to gain more weight than if you feed it rat chow, which tastes kind of like bark. You can put an animal in and give it access to exercise, and it'll tend to gain less weight. Or there are animals that are genetically resistant to weight gain. But most animals and most humans gradually gain weight through their whole life. That's a rat study, but it doesn't apply to humans. I just came from clinic this afternoon, and when I see somebody who struggles with their weight, I tend to say, draw me a picture of what your weight's done over your life. And the person will say, well, I went to college and I gained a little weight, got married, I lost a little bit of weight, I got pregnant, I gained some weight. I went to Weight Watchers, I lost a little bit of weight. I had this awful job, my husband's a bum, I gained some weight. I took a medication, I lost some weight. This is what I see in clinic. And this is not a set point. This looks just like the rat data to me. It's a trajectory of gradual weight gain through life, punctuated by periods where people make changes in their behavior or take medications that change that. But there's just this gradual tendency towards weight gain. So if that describes the system, how is it regulated? How do we maintain energy homeostasis? This is how I think about it. Somehow the brain is measuring things all day long. It measures what we're eating, how many calories are in what we eat, how many calories are we burning every day, what's the gas tank look like, and it's a remarkable system. Again, I could spend 10 minutes talking about the numbers, but for somebody who gains 40 pounds over their life, you say that's a moderate weight gain in that person. But the energy balance that represents is on the order of 8 or 10 calories a day. And people who maintain their weight through their life, that's a regulation with a precision of 1 or 2 calories per day. I mean, and that's because you're multiplying how much we eat over years. So over the course of 40 years, a person might eat 20,000 pounds of food. And so if their weight only changes by 40 pounds, it's actually a remarkably regulated system. I say energy in, energy out, that's calories. Calories is what we eat, calories is what we burn, but it's actually not calories, it's food, and especially macronutrients. So we'll eat a certain amount of fat, glucose, and protein, and every day we have to burn that same amount of fat, glucose, and protein, or else the stored nutrients, fat, glucose, and protein will change. If we eat more fat than we burn, then we accumulate fat. Now the biochemical pathways have ways of interchanging some of these. But again, it's remarkable that the body can not only balance calories in, calories out, but balance that types of food that we eat. You're in the morning, you pour a little milk on your cereal, you go, that looks pretty good. But actually, your brain just did something remarkable there. Within 10 calories, when measured over years, it's making this precise measurement of what's going on. We talked about energy in and energy out. So let's talk a little bit about what those things mean. I'm talking to you like my students here is what I'm doing. What is energy expenditure? Well, there's something called basal metabolic rate. That's how many calories it takes to just keep your body warm, keep your heart pumping, make your kidneys work and stuff like that. There's something called the thermic effect of food. That's the energy cost of digesting and assimilating nutrients. So when I eat a bagel, my body's got to take it apart, turn it into glucose, move it around, stick it into a cell. That all requires energy. And so some of the calories I burn every day is just to assimilate the food. Some of that is what we call obligatory and some is facultative. That means if you do actually the chemical cost of these things, you get a certain number, but the body's inefficient. Some people can store that nutrient efficiently and others less so. And so this is a variable number. What I'm talking about here, some people, same weight, some people burn more calories than other people. Where does that variability come from? It comes from something like this, the efficiency of storing food. One of the most variable components is energy expended in physical activity. Just like thermic effect of food, there's mechanical work and then there's waste and inefficiency. When I jump in the pool and swim across the pool, I'm a 70-kilogram man, I swim 50 yards. That is a certain amount of mechanical work. But I'm a terrible swimmer. You put Michael Phelps in the pool, he can swim 50 yards and burn almost nothing. He's way faster than I am. I'm just inefficient. So when you read on that machine that you're walking on the elliptical or the treadmill will give you some calories. It's not super accurate because part of that is how big are you? You're a bigger person. It costs more energy to move that far. How efficient are you in your walking? People who haven't exercised before tend to be inefficient. They burn more calories. And then you gradually learn how to do it. You become more efficient. Well, who cares about this anyway, Dan? Well, this is your total energy expenditure, which equals how much you get to eat every day. So if the body is trying to maintain energy balance, the body is somehow measuring this energy expenditure in all these components and then deciding how much you're going to eat. Let's talk a little bit about the regulation of how much we eat. And again, we could spend a whole hour on this. It's a fascinating topic that we've really learned so much about. People who think about appetite and how the brain regulates appetite think about these things in sort of two buckets. They call them physiologic or homeostatic mechanisms. So this is the part of the brain that measures calories in, measures calories out, and tries to balance those. And what it has to do is to integrate short-term signals, which mean how big was that meal that I ate? How long has it been since I ate before? What's happened over the last couple of hours? But it's also got to integrate these long-term signals, like how much fat have I stored? Do I need more stores in the gas tank here? This is homeostatic, trying to maintain energy balance. But most of us don't eat only for those reasons. There are non-homeostatic mechanisms, things like reward and motivation. Some food tastes good. You put good food in front of me, and I'll eat more of it. Cognitive and executive decisions. You might say, I'm going to eat less because I don't think I should eat that. That's a cognitive decision you make. There are environmental and social cues. I go to my mom's house and she says, eat this, and I eat it. I may not be hungry. I may not even like it. But my mom said I should eat it, so I'll eat it. So there are other things that are not related to this homeostatic approach, and yet the body somehow has to integrate all this information such that we tend to maintain weight over time. Let me just show you a little bit about how this system works. Here's a brain, and in the hypothalamus, this part of the bottom of the brain, it's like brakes and gas. There's a pathway that we call the anabolic or assimilating energy pathway. These neurons stimulate food intake and they inhibit energy expenditure. There's another pathway which we call the catabolic pathways. These are specific neurons with specific neurotransmitters in them. And those neurons, if you stimulate them, they inhibit appetite and stimulate energy expenditure. The net effect is that if we stimulate the anabolic pathway, for example, then I'm eating more, I'm burning less, and then I'm in positive energy balance. So this happens Thanksgiving, I guess. We turn on the pathway that stimulates food intake and inhibits energy expenditure. I'm in positive energy balance, and my adipose tissue expands. But it's a regulated system. So there are feedback signals that come from the fat tissue back to the brain that if I'm gaining weight, then the fat tissue says to my brain, turn on the breakdown pathway and turn off the storing energy pathways. So it's like brakes and gas. The system is set up to maintain this very close homeostasis because of these parallel pathways. What we've learned over the years is some of the players here. Leptin is a hormone made by adipose tissue. Insulin is a hormone made by the pancreas. These hormones go up when somebody gains weight. You know, we worry about that. We say somebody's insulin resistant, they have high hyperinsulinemia, but that's a sign to the brain that I've eaten too much and I'm gaining weight. It shuts off appetite and increases energy expenditure. Same thing with leptin. There are short-term signals that come from the intestine. Ghrelin is a hormone made by the stomach and proximal small intestine, small bowel, and it stimulates appetite. PYY and GLP-1, these are hormones made by the more distal bowel, and they shut off appetite. So with each meal, there's this rhythmic change in these hormones. If I haven't eaten overnight, my ghrelin level is high, my PYY is low, I'm hungry, I have a meal. Now as the food comes in, my intestine senses the nutrient and the ghrelin levels go down, my hunger goes down, PYY goes up, my satiety goes up, and I stop eating. So, and again, we can spend a lot of time on each of these things. The message I want to give you is this isn't just I choose to eat a bagel. I do choose to eat a bagel. But underneath that, there is a whole lot of biology regulating it. Why do I eat a bagel? Well, it's not just because I need to maintain energy balance. I happen to like bagels. And so what is that? Pleasure and reward. We've learned a lot about the neurobiology of reward from drug addiction. The people who studied why do people become addicted to drugs tried to understand the regions of the brain that are responsible for that. Turns out, though, we don't have pleasure just for drugs, we have pleasure for other pleasurable things like food. And so these same brain regions that regulate drug addiction and other pleasurable sensations relate to food intake. What we found is a particular brain regions, for example, the ventral striatum, and particular neurotransmitters, in dopamine being the most important one. So this transmitter in this brain region correlates with rewarding stimuli. And so you might wonder, do some people gain weight because they need more reward or because they experience more reward? How does that actually work? The most recent data suggests that people who tend to gain more weight over their life have fewer dopamine receptors in these regions that relate to reward. I mean, I talk to people in clinic all the time that say something like, I get stressed out and I've got to have a piece of chocolate. Actually, my wife says that. I have to have a potato chip myself. So what you can see is these neurotransmitters that are involved in mood and cognition interact with these basic weight regulatory systems in a way that actually turns up the gain on something. What happens is I think if we are hungry, what happens is that we actually find some foods more pleasurable. And if you're full, the foods are less pleasurable. So how does my brain get me to eat something? It makes the food more attractive to me. And how do we get people to lose weight? The same pathways, if you turn them down, people just don't find the food appealing anymore. We'll talk about medications in a bit. These newer medicines are really just changing dramatically how we treat obesity. And when you talk to these folks, they just say, yeah, the food's just not appealing to me. I had a woman actually just last week on one of these newer medicines. It's not in the market yet. And she said, it's a problem, actually. She said, my husband took me out to dinner at Linger. Some of you have ever been to Linger? It's a great place. She's like, it's a big deal. She says, I look at the food, I'm like, yeah, not happening, because the medication changes these fundamental mechanisms about how the food is perceived. Well, let's talk a little bit about things that predispose to weight gain. We'll touch briefly on genetics, changes in dietary intake over time, talk about physical activity and changes over the last 1,000 years in physical activity. I won't spend too much time on this. I'll mention sleep briefly. But there's a wide range of things that predispose to weight gain. And for an individual person, one of these might be a big deal. Somebody may get a job where all of a sudden they are working a night shift. That could have a big effect. Somebody could get married and the kind of food their husband eats changes, and that could have an effect for them. So these environmental things can interact with the regulatory system and change that trajectory of weight gain. Let's talk about genetics. There are these monogenic or syndromic obesities. These are single genes that dramatically promote weight gain. Sorry, let me take a sip of my Diet Pepsi. What am I drinking? So this shows that a single gene can have a dramatic effect on weight. These are uncommon, and these individuals develop early onset, meaning they start to gain weight when they're 1 or 2 years old. Often they have other associated features, sometimes reproductive problems, sometimes cognitive issues. Common obesity, the kind that all my friends and the patients I see typically have, is polygenic. There's many genes involved. This was actually a couple of years old. I've heard that the number has gone up to almost 300 different genetic loci have effects on weight. And these are important effects. 30 to 70% of weight, BMI being a measure of that, is inherited. So it's not 100%. In one family, you see this brother is thin and this sister is heavy. But in general, families that struggle with weight have a genetic load for weight. Of these 140 loci, some of them have more modest effects, some have bigger effects. What's a big effect? Here's this gene. This is the most potent of these 140 loci that's been found. It's called the FTO locus. And so you have 2 alleles. If you have the 2 alleles that are for thinness versus the 2 alleles that are, because you have 2 copies of the gene, that promote weight gain, the effect size is 1 kilogram per allele. That means if you're homozygous for this, you weigh 2 kilograms, 4 pounds more. So it's a tiny effect size. So what we have are hundreds of genes, each with small effect sizes. Why would we worry about that? Well, maybe we could do a genetic test. So you have a child, or there's a lot of weight problems in my family, let's say. We want to say, Johnny, are you going to gain weight? Let's do a genetic test, see if you're predisposed. Here's an analysis of 2.1 million common variants. So 100 loci, each of these can have multiple variants, different flavors at that site. So there's a bunch of different variants. And the difference between people with a high load genetically for obesity versus a low load, it's 13 kilograms, 26 pounds. So it's not a huge effect. And so right now there are genetic screens for this that you can get, but they just don't work very well. So genetics is important, mostly polygenic, effect sizes are small, not ready for prime time diagnostically yet. How about dietary factors? Diet's clearly important. And, you hear people say, 1,000 years ago, what did we eat? I mean, picture yourself here in Denver 1,000 years ago. Wake up in the morning and say, where's my coffee? I want some coffee. Where am I going to get coffee from? And what are you going to eat here in Denver 1,000 years ago? Maybe kill one of those, I don't know, prairie dogs or something like that. I don't know if I could catch a prairie dog myself. And so people say the reason we're gaining weight so much now is that the food is everywhere. It's there all the time. It tastes really good. Well, how would we know whether a particular dietary factor is relevant or not? You'll hear people say, well, don't eat carbs or don't eat fat or eat more protein or drink more water or, any one of a number of things. How would we know any of that? Well, you could do an epidemiologic study. You could take 1,000 or 70,000 people and say, 70,000 people, tell me what you ate. And these people say, I eat a lot of bagels. These people say, I eat a lot of basmati rice. Now you follow them for a long time and you see who gains weight and who doesn't. Epidemiologic studies are very good because they have huge power, 70, 80, 100,000 people. But the causality is not there. I mean, and people do you believe what they say? If Dan says he doesn't eat bagels, do you believe him? I don't know. So that's the problem with epidemiologic studies. Strong statistical power, but causality is sometimes difficult. You can do short-term intervention trials. Pick a group of people and feed them something, and these people you feed them something else, and you see who gains weight and who doesn't. That's pretty good because you have good control of diet, but usually they're short-term. You don't do these for years, and usually you have sort of a surrogate marker of something you can measure in a few months. So that's the limitation there. You can do animal studies like what I showed you with the rats. Those are good because they're highly controlled. And so that's a positive, but they're animals, they're not humans. You could do prospective randomized trials in humans with hard endpoints. These are the best studies. These are the gold standard studies. So, people will ask me, well, what do I think about eating carbohydrates? And there's no simple answer to that. My answer is, well, there's epidemiologic data that shows one thing, there are animal studies that show another, and I try to synthesize this all together and say, my best answer from the literature is this or that. I'll show you a few examples of that. And what does the literature show? I think, there's strong, or you could say high-fat diets are what cause weight gain. There's very strong animal data for this. There's strong human data for this. High carbohydrate diets, actually, there's less data for this, even though this is a popular idea. And for some individuals, this seems to be a big deal. High fructose corn syrup, there's strong data that the prevalence of obesity has increased at the same time that high fructose corn syrup appeared in food. There's some specific biochemical things that fructose does. It's different than glucose, it's different than other carbohydrates, and so it may have some uniquely harmful effects. I used to poo-poo this water thing. People say, oh, drink a glass of water with every meal. There's actually some very interesting data now that people who gain weight are more dehydrated than people who don't gain weight. And there's this crosstalk between the thirst brain centers and the hunger brain centers. And maybe people are not drinking as much, and that somehow makes them more hungry. So this is an evolving area. I think I don't know what the answer to, and people always say, how much water should I drink? The problem with that is it depends totally on temperature and activity and clothing. But I think water may be more important than I used to think. I'll just show you the latest one here, which is ultra-processed foods. What is an ultra-processed food? These are the foods that come in little plastic containers, and they are produced by industrial methods, not culinary methods. That's the official definition. It means it's food made by big machines, and there's like chemical processes involved, as opposed to my mom or my wife tonight. She gave us, what did we have? We had tomatoes from the garden. It was so good, on a piece of bread that she made. That would be more culinary approaches to food. I still want to get some Cheetos on my way out here though. So ultra processed food, that would be a Cheeto, is what that would be. So this is an example of one of those short-term interventional trials. Kevin Hall did this. He took people and he fed them for 2 weeks, either an unprocessed diet or an ultra-processed diet. Same composition, same fat, carbohydrate, protein. He let people eat what they want. And what happened here, this is their weight over just 14 days. People on this ultra-processed diet gained about 2 kilograms relative to people on the unprocessed diet. And they tended to overeat this food. And so this is, like I said, different kinds of study, short-term interventional trial. There's epidemiologic data on this. There's some basic science data on this. So this is an area I think we're becoming more aware of. We focused on diet composition, grains, fiber, things like this. I think this idea that maybe the kinds of food that are in plastic bags maybe is not so good for us. Well, how about energy expenditure? And are we gaining weight because we are burning less calories? This is the relationship between how big we are and how many calories we burn. Remember, I told you that 24-hour energy expenditure and all the components. Well, here's some numbers. If I weighed 100 kilograms, so each of these dots is a person, and they measured how many calories a day they burned, and they just plotted it on a graph here. And what you can see is big people, 100 kilogram people, they on average are burning about 3,000 calories a day. If they're maintaining that weight, they're eating 3,000 calories a day. Somebody who's 50 kilograms in size, they're eating 1,700 calories a day. There's variability here. There are people who weigh 50 kilograms who are eating 2,500 calories, some are only eating 1,400. So that's that efficiency piece. Some people are more efficient, some are people less efficient. So the question is, this is 24-hour energy expenditure, so it's physical activity and resting metabolic rate. So one question is, are people gaining weight now because we're burning fewer calories? We're more for some reason. And the most telling experiment to me, these are the Pima people. These are Pima people living in Arizona. Who are the Pima people? These are folks who came from Russia and walked across the Bering Land Bridge, walked from Alaska down to Mexico City, and then walked back to Phoenix. Well, who lived through that? That was sort of a selection process. I probably would not have made that. The Pima people living outside Phoenix have a high prevalence of obesity, and 50% of these folks have diabetes. So they've been studied. There's an NIH research center there. But some of the folks there found a group of Pima people living in northern Mexico, living a traditional agrarian lifestyle. And this is what those Pima people look like. Same genetics, but totally different body phenotype. Almost no diabetes and only 15% obesity. So what's the difference? Are the folks in Phoenix eating more food, or are they less active? What's the cause of this transition? Who would guess what? Here's the figure. The triangles are the US Pimas. The open circles are the Pima people living in Mexico. So what you can see is the 60 kilogram Pima person in Arizona has lower energy expenditure. The difference is the Pima people in Mexico are highly physically active. That was the big difference. The Pima people in Mexico are eating 3,500 calories a day, even though they're living a subsistence environment. Why? Because they're super active. So this is the kind of data that says, maybe it's not the food we're eating. Maybe it's that we're all sitting around all the time, that we were really built. Again, I picture yourself here in Denver 1,000 years ago. How much work is it going to take you to get a cup of coffee? That's going to be a big problem. Here's some other data about that. This says between 1960 and 2010, what are we doing? Well, employment service jobs went from 50% to 80%. Agricultural jobs went from 10 to zip. Goods producing jobs, 40% down to 20%. And the effect of this work-related physical activity was that over these 50 years, the people doing moderate physical activity went way down. People who are either sedentary or only lightly active increased dramatically. And the effect of that was the energy expenditure at work. Remember that most variable component of energy expenditure is physical activity, and most of us spend much of our day at work. And what happened was men went from expending 1,500 calories a day to expending more like 1,400 calories a day. And 1,400 calories a day, maybe that doesn't sound like much, but remember what I said about how much energy imbalance it takes to gain weight? The people who did the math said that much of the rise in the prevalence of obesity could be attributed to this fall in physical activity. food's important, what we eat's important, but how much we move, I think, is important as well. How about sleep? Epidemiologic studies have shown that shortened sleep time is associated with weight gain and type 2 diabetes, as is shift work. Experimental studies, so again, short-term interventional trials, you take a bunch of people, say, you only get to sleep 5 hours a night, and you folks, you get 8 hours a night. Or take people and say, you have to work the night shift, and you measure a bunch of stuff, and what you find is people who don't sleep enough or who are up at night, they get more hungry, they have changes in their metabolism, they become insulin resistant, and they change their food preferences. And it's interesting, this work happens at a time when the science has taught us a lot about these circadian cellular systems. This started with trying to understand, well, why do we wake and why do we sleep? Isn't sleep crazy? The idea that each of us becomes unconscious for 8 hours. You're just laying there, you're unconscious. The animal could, the wildebeest should just eat you, right? This is an incredibly dangerous thing to do. And it is so fundamental. Even flies, every organism sleeps. What is it doing? Why do we sleep? What's happening there? Well, it happens because there are clocks inside our body. There's a clock in the suprachiasmatic nucleus that makes us fall asleep and wake up. The biology was understood there. And they said, these clock genes, where are they? And they found these clock genes in pretty much every cell of the body. There are clock genes in your insulin cells. There's clock genes in your liver. Well, there's clock genes in your fat cells? Why should there be a clock in my fat cell? Well, if you take the clock out of an insulin secreting cell, you get diabetes. You take a clock out of your liver, you get hypoglycemia. So what it implies is that our body is set up not to respond to our eating, but it's to anticipate these things. The body anticipates when we're going to be active, it anticipates when we're going to eat, and these metabolic systems prepare for that. And so and we're designed for that. With sun comes up in the morning, we need to go out and kill the wildebeest. Sun goes down, we need to go to sleep. But now it's the middle of the night and the lights are on. And so we are all living in an environment that is very circadian misaligned from what our bodies are designed for. Let's talk some about weight regain, because this is what I see in clinic all the time. There's a bunch of different ways to lose weight, medicines, diet. People can lose weight. This is weight over time. People lose weight, but then they regain the weight. Why do people have such a hard time maintaining weight loss? Well, actually, you'd expect that if this was a regulated system. If it's a system that wants your weight to be here and you just cognitively make it go here, there are adaptive responses that push the weight back where it wants to be. So why is it so hard for people to maintain weight loss? It's because weight is regulated in a manner that with weight loss, energy expenditure goes down. You burn fewer calories, so you get to eat fewer calories. Your metabolism changes such that you store the nutrients you eat, and your appetite goes up. So you need fewer calories, but you want to eat more. And these systems tend to push the weight back where it belongs. These forces can be counteracted with different treatments, exercise, diets, environmental changes. We'll talk more about that in a minute. This is the sort of magnitude of this. These are our components: resting metabolic rate, thermic effect of food, activity, energy expenditure here. So before weight loss, somebody might need 2,600 calories a day. Now they go on a diet and they're eating less and their weight goes down, and then their weight stabilizes. And the person always says to me, what's the matter? I'm still on my diet. Why am I not losing more weight? Because they're in new homeostatic balance. They're only 2,200 calories a day because their energy expenditure has gone down. Their resting metabolic rate has fallen. It's actually fallen more than you would expect. The body's becoming more efficient. The amount of energy they expend when they exercise goes down because they weigh less, but also their body has become more efficient for the same exercise. Their thermic effect of food has gone down because they're eating less food. So the person then has to keep eating this amount of food forever, or they regain the weight because that's their new energy balance. Well, that's kind of hard. I actually didn't even tell you about what happens with aging. When we can calculate resting metabolic rate, and our resting metabolic rate goes down by a fixed amount every year as we get older. Just like your heart rate your maximal heart rate goes down as you get older. If you do the math, to maintain your body weight for your whole life, you actually have to eat about 600-700 calories less when you're 60 than you did when you're 20, just because your body's more efficient. It's kind of discouraging, isn't it? I think that's why there's this gradual awakening, is the body is gradually becoming more efficient as we get older. But this is a real deal, and the numbers are hundreds of calories, and that's, the one person in the couple has lost weight, and the other person's maintaining their weight, and this person's eating very little. And they say, why do you get to eat all that? And I don't get to eat all that. This is the reason. The energy expenditure goes down. How about hunger? This is a study where they took people who weighed 95 kilos, they lost, 10 kilos, and they maintained that weight loss over a year. So lose weight, maintain it. They regained it some. Again, it's hard to maintain weight loss. And they measured the hunger. They got up in the morning and they said, how hungry are you? On a scale of 1 to 10, oh, I'm a 4. And then they say, okay, have breakfast. How hungry are you? My hunger goes down. And then by lunchtime, I'm hungry again. So this is self-reported hunger over 4 hours with a meal. So after they lose weight at 10 weeks, it's the blue line. They are more hungry. They're hungry all the time, a little bit more than they were before. How about a year later? Did it get any better? No, they're still more hungry than they were at baseline. So energy expenditure goes down, hunger goes up. Why does hunger go up? These hormones change. Ghrelin is that hunger hormone from the stomach. It goes up and it stays up for a year. PYY, CCK, these are the satiety hormones, they go down. So the body is telling you, the body is trying to regulate weight at this point. You're not agreeing with the body and it's trying to fight you biologically. This is what people who struggle with their weight have to deal with. So when you lose weight, you go from a bigger person to a smaller person, your hunger goes up, a bunch of hormones change to try to make you more interested in food. Your energy expenditure goes down for a wide range of reasons, hormonal and just physical. And this creates this energy gap, which predisposes to weight regain. Yeah, but what if I just do this longer? How about, doesn't my body just get used to this thing? Doesn't this get easier somehow? This is another rat study that Paul MacLean did. So he takes some rats. These are rats on bad tasting rat chow. This is rats, a high fat diet, and they gain weight. So now he took the rats and he put them on a diet and kept them there. And some of them he let go back off the diet immediately, some at 8 weeks or 16 weeks. The question was, if he just kept them on the diet long enough, would they just sort of get used to this? What do you think happens? The longer they're on the diet, the weight goes back not to where it was, but to where it would have been. And so the ones who are on the diet the longest were the farthest away from the defended weight. And so they gain the weight fastest and gain the weight the most. It's frustrating, isn't it? But again, I think this is my understanding of the biology as best as I know it, and this is what I try to talk to my patients about. There are people who maintain weight loss through cognitive means. What happens is they become very good at it cognitively. They know what foods they can eat. They know how to count calories. If their weight starts to go up, they have whole strategies for doing it. They're highly physically active, but they spend a bunch of their brain power maintaining their weight because it takes a lot of energy to overcome these basic homeostatic mechanisms. So in summary, weight is regulated around a trajectory of gradual weight gain. Energy intake equals energy expenditure. Weight is stable, although we're really talking about foods here. I'm going to keep going with treatment in a minute here. I know I'm talking kind of faster, but I'll just stop whenever you want me to stop. You'll get bored. So appetite regulation is complex and involves both homeostatic and non-homeostatic factors. And with weight loss, there are compensatory mechanisms that promote weight regain. Well, let's talk about treatment. When I see folks in clinic, I use a BMI. This is a BMI you can find yourself on here. What's your weight? What's your height? I'm actually 5'7" and I weigh 160. So I'm right here at 26. This is normal weight. This is overweight. This is obese. So I'm overweight. I'm just in the overweight category. We're so used to people weighing a lot that I don't know what you think. But I'm in the overweight category. How do we categorize people? Underweight is a BMI less than 18. Normal is 18 to 25. Overweight is 25 to 30. Obesity is mild, moderate, or more severe. 30 to 35, 35 to 40. Greater than 40, that's more severe. Why did we pick these numbers? It's because they're associated with health problems. Obesity is a degree of excess weight, especially excess fat mass, associated with health problems. Well, there's all this controversy about this. This past year, we've seen this in the news. AMA says BMI is no good. Doctors move beyond BMI as a health measure. Why is this controversy? Well, I acknowledge BMI is only an estimate of body fat. And defining obesity as a BMI greater than 30 suggests that everybody has that same risk, which isn't true. There are people who have a high BMI, but they're otherwise healthy. And in fact, in older people, there's some evidence that maybe you do a little bit better with a little extra weight. So there's some controversy there. I think the big thing is when somebody says, use the word obesity, it's stigmatizing. People take that personally, like it's a personal criticism. And so we struggle with this word because of the bias and stigma associated with it. So people are looking to redefine obesity. But the problem is, what are we going to use if we don't use BMI? It's a very easy to use measure. I saw this paper today from in JAMA that said the waist and hip circumference were maybe better. let me tell you, we did studies where you measure waist and hip circumference. It's not easy to measure hip circumference, like exactly where do you measure it and how do you get it consistent? And you come at somebody with a tape measure, a guy like me comes at somebody with a tape measure, people are not happy with that. They'd rather be on a scale than have you come out with a tape measure. So there's no easy way out of this BMI thing. And let's not forget that this is BMI and this is risk of diabetes. The higher your BMI, the higher risk for lots of things, blood pressure, heart attacks, strokes, death. So BMI really does predict risk. People say, but my BMI is up and I don't have a health problem. You could say that about blood pressure, glucose. There are people with high blood pressure who don't have a stroke. There are people with high blood sugar who don't go blind, but it's a risk factor. And it's one that I think is potentially treatable. So I think BMI is a good thing. Because all of these diseases, pulmonary disease, sleep apnea, fatty liver disease, gallbladder disease, infertility, polycystic ovarian disease, arthritis, cancer of multiple sites, heart disease. There are so many health problems associated with excess weight. If people didn't have excess weight, many of the medical problems I see in clinic would go away. So if we had an effective treatment for obesity, it would have a dramatic effect on health problems across the board. So what do we have for treatment? This is what I say to my people. Somebody comes and says, we came to clinic today. What am I going to do about weight? So, well, you can accept your weight where it is. I can't do that. This weight is terrible. You could do diet or exercise things. I already do diet and exercise. You could take a medication. Well, those things are dangerous and expensive. You could have surgery. Oh, that seems too radical. Sorry, those are the choices. It's a conversation I have over again. It's the person's choice. What do you want to do? Many of my people accept their weight where it is because they don't want to do these things, or they think they're already doing, or they are doing them and they're having some level of success. Diet and exercise have modest effectiveness and almost no risk. Surgery has much more effectiveness and much more risk. So it's a question of how much effectiveness do you want and how much risk and cost are you willing to take? And that's what I go do in clinic, is try to help people sort through these choices. In general, if your BMI is not that high, do something that doesn't have much risk. If your BMI is high and you have a lot of health problems, okay, now let's talk about something that has more risk, because it's all risk benefit and it's all a personal choice. So less weight, lifestyle is good. BMI over 27 and you have some health problems, arthritis or high lipids or diabetes. Okay, let's use medications. Surgery we consider when the weight is much higher. Diet. Does diet work? This is a classic study. Again, what's the gold standard diet study? Long-term prospective randomized trial with a hard endpoint. So this takes people with pre-diabetes and obesity and put them on a good diet. And they only lost 5-6% of their body weight. So this is a 200-pound person who loses like 10 pounds. Doesn't seem like much. And they only maintain it, and they regain some. But what happens when they did that? Their risk of developing diabetes fell by 58%. So this is where the idea that a modest weight loss is helpful comes from. Studies like this, prospective randomized trial, modest weight loss prevents diabetes. Wow, that's powerful data. This was a low-fat diet. Doesn't mean a low-carb diet isn't a good diet. It's just what they happen to do in this study. Here's a Mediterranean diet. This is more kind of fruits and vegetables, more olive oil. This is a moderate fat diet, not a low-fat diet. And it's a prospective trial looking at heart disease. There's the usual low-fat diet. Here's a high olive oil with nuts kind of a diet, and cardiovascular disease go down. Another gold standard kind of trial. So my Mediterranean diet's a good diet. I think a low-fat diet's a good diet. How about this time-restricted eating thing? This is popular now. Again, relates to this chronobiology thing, the idea that when we eat might be as important as what we eat is the concept. And again, there's animal data that support this. This happens to be a window of time of 8 hours every day compared to your usual caloric restriction diet. It was 90 people randomized to this 8-hour window versus a daily caloric restriction. Here's the weights. Here's the control group, gradually gained weight over a year. Here are the two diet groups, the time-restricted eating and the orange, caloric restriction in the blue. Basically, they're the same. If you look at weights, some people lost more weight with one approach or the other. So there's tremendous variability here. But there was no both the time-restricted eating and caloric restriction lost more weight than the control group. So both of them worked, but there was no difference. So the take-home message is this alternate day fasting stuff, time-restricted eating, they're reasonable diet approaches. They have advantages for some people, but they're no better than the other dietary approaches. Well, what's the best diet? I like this study. This compares the Atkins diet, a very low carb diet, the Zone diet, which is kind of higher protein, Weight Watchers kind of standard diet, Dean Ornish diet. This is a very low fat diet. These are individual people and how much weight they lost. And what you can see is that with any of these diets, some people lost a bunch of weight and some people lost nothing. So which is the best diet? The best diet was the one you could stick to. This is the dietary adherence. The people who adhered to the diet, and by this dietary adherence score, that's who lost weight. So what's the best diet? The one you can stick to. Because what you're trying to do is, with your brain, fight all that biology. And if it's easy to do and you can actually sustain it for a long time, that's the real key there. How about exercise? Exercise is great for general health. It's not a great way to lose weight. It's very important in maintaining weight loss. I bring this up because we all should be getting 2 hours and 30 minutes a week of moderate intensity, or 1 hour and 15 minutes a week of vigorous intensity aerobic activity, and muscle strengthening twice per week. That's what all of us should be doing. It's probably insufficient to lose weight or maintain weight loss, but I'm telling you all, we should all strive for this. I strive for that. Let's talk about medications. I know I'm going fast, but it's a lot of information. I hope you're sticking with me. I'm going to talk even faster for the last 5 minutes. So, how about medication? Key principle: medications for weight loss only work as long as you take them. This isn't a bladder infection. It's not like you take it for a while, the weight goes down, and now you stop it and you stay there. No, it's like a blood pressure medicine. If you took a blood pressure medicine, the blood pressure would come down. It wouldn't keep going down; it would just stay there. And then if you stop the medicine, the blood pressure goes back up. That's what this is like. A weight medicine will cause weight loss, plateau. That's the drug effect. And then if you stop it, the weight will tend to come back, and you'll be on that gradual trajectory. So there'll probably be some weight gain because that's the natural biology. So somebody who wants to use a weight loss medication, I say you got to be open to long-term therapy. They never believe me. It gives a 3 to 15% loss above diet alone. So variability depending on the drug, I'll show you that. They're typically not paid for by insurance right now. So people pay out of pocket. So cost becomes a major factor with these medicines right now. They vary in cost from $20 a month to $1,200 a month. Wow, that's a lot of money. They vary in effectiveness, mechanism of action, and side effects. So the conversation I have with people is to say, you interested in medicine? My diet's not working. I want to lose my weight. What are the options? So I tell them the medicines and what the options are. And there's a great deal of variability in response. Just like I showed you with the diet. Same Dean Ornish diet, some people lose a lot, some people don't. Same thing with the medicines. That's probably because there's heterogeneity in what causes the weight problem. And so this person has this pathology and this person has this. So the drug works for you, but not so well for you. That's so the variability in response is common. And they're rarely prescribed. In the past, only 1% of people eligible for an anti-obesity medicine ever got a prescription. Diabetes, it's 80%. There's this idea that we prescribe medicines for diabetes and blood pressure, but we don't prescribe medicines for weight. There's this idea that it's not valid. Actually, I saw a guy today, and he was using the same kind of language. He was talking about himself. He said, I'm not taking the easy way out. I'm thinking, this is a biologic problem. Would you say that if I said you need a blood pressure medicine? But we have this idea that we have control over this system. Here are the medicines. Phentermine is an old medicine. It's cheap. It's like $15 a month. It gives a modest weight loss. It's only FDA approved for 3 months because it's so old, it's never studied very well. Phentermine topiramate is the most effective pill we have. It gives an 8 or 10% weight loss, costs $100, $200 a month. And then there are these newer medicines, these GLP-1 agonists, the most recent one being semaglutide. You've heard about this one, Wegovy, Ozempic. This gives more like 15% weight loss. So the old medicines, 3 to 5% weight loss. The new medicines, much more weight loss. But look at the price here, $935 a month for semaglutide. Who's going to pay that every month for the rest of their life? That's potentially a problem, right? Here's just some data about that semaglutide. There are 5 semaglutide studies. This study was for weight management. This is weight management in diabetes. This is weight management combining a medicine with really good lifestyle treatment. And this is long-term. So here in the general weight management, 15% weight loss. That's really meaningful weight loss for a lot of people. And there's real health benefits to that. People with diabetes lose less weight. This, in all the studies, no matter what the medicine, people with diabetes tend to lose less weight with medicines. This is super interesting. This is the idea that should we do a really good lifestyle, and is the lifestyle part really important for the medicine's effectiveness? And so this is a great lifestyle program. This is not so great. The idea was you're going to get more weight loss in this one. No difference, really. So it turns out, I think where we're moving is these highly effective medicines, the medicines do it on their own. And the role of lifestyle, I think, is changing. I'll say more about that in a minute. Because here's our old medicines. The 1959 was phentermine, semaglutide was here in 2021. And there are a bunch of these coming along. And these newer medicines are even more potent. Let me show you some of those. This is tirzepatide or Mounjaro. It's already FDA approved for diabetes, but here's the obesity data. This is 2,000 people, not diabetes. And look at these weight loss, 20%. So semaglutide is 15%. This is 20%. Here that group, actually, if the people tolerated it, took it, this is counting people who dropped out. The people who concluded it was 22% weight loss. And here's the variability in response. 39% of people lost more than 25% of their body weight. That's like bariatric surgery kind of weight loss. So that is Mounjaro. Here's one that's not even on the market here, retatrutide. This is what we call a triple agonist, 3 different gut hormones, GLP-1, GIP, and glucagon. And this was the results there, 24% weight loss, all comers, over just 48 weeks there. And look at this, 26% of people lost 30% of their body weight. This is definitely surgical kind of weight loss. So semaglutide, the one that's in the news, very good. Tirzepatide, better. Semaglutide, cagrilintide, better still. Retatrutide, better still, meaning more weight loss. So it's a new world out there. The efficacy is getting greater and greater, and will provide bariatric surgery level weight loss. And again, we're doing studies with it. And this is a wild thing for people to experience. They have this idea, I want to weigh what I weighed in high school. Okay, now they're on the medicine and they're really losing weight. And they're like, wow, this is kind of weird. I have no interest in food. What do I do when I'm around other people? I'm feeling kind of weak because maybe I'm losing some lean body mass. I thought weight loss was going to be great. Like I'm the doctor here, right? I'm trying to make sure people are safe. And I found myself saying, we have indications for thinking about medicines, but we don't have any indications of what the goal is. Like blood pressure, we know, give people blood pressure medicine until your blood pressure is that. We've just not had good therapies here, and so we don't know what the right weight loss is. We've used surgery in the people who are most severely affected, and it's big time treatment, but the person has surgery and they get what they get. With these, you have to dial it into what they want. Well, what do they want? What do I want? What's right? We don't have a good answer for that now. We could combine these. These are single agents, so you could combine these together and get even more weight loss. Do we really need that? It's $1,000 to $1,200 a month. Can we afford this? Cost of the healthcare system would be potentially enormous. I think I showed you, it's like 40% of everybody's obese. If 40% of the country took a medicine that's $1,000 a month for the rest of their life, that doesn't sound right. So how are we going to actually do this in the coming years? The prices will come down, but still, it's a big challenge. And these things have some risk. Nausea is the most common side effect. There's this marked reduction in appetite. I think this is going to change the food environment. I think in the future, there'll be enough people on these medicines that the food environment will change to meet the needs of these people, which will be different than the food environment now. People can get gallstones, pancreatitis. So there are health problems with this. But I think for some people who struggle with their weight, this is dramatic new therapy. 2 words about bariatric surgery. Here are the common surgeries: sleeve gastrectomy. What I say to my patients is, there's your stomach, it's the size of a football, and now we turn it into a banana. So it's basically take this part of your stomach, cut it out, throw it away. Here's the gastric bypass. There's your stomach. Instead of a football, it's like a golf ball. Then we take this piece of intestine and hook it up here. This is a more aggressive surgery. This is easier to do and a little less effective. Does it work? Yes. Average of a 30% weight loss. This is an old study, the Swedish subject study. 20 years out, the people still are maintaining a 28% weight loss. Again, variability, like all these. Some people regain, some people lose more. But on average, very durable, good effect. And this surgery lowers mortality. This is a case control study. The surgical patients in yellow have more mortality the first year because that's surgical complications. But by year 2, lower mortality by almost 50%. And what are they not having? They have fewer cardiovascular events and they have less cancer. And this is particularly women. So we know excess weight predisposes to cancer. This shows that then you lose the weight and your cancer risk goes down, especially these hormone-sensitive cancers like endometrial cancer, breast cancer. So the benefits of bariatric surgery, people who have type 2 diabetes, dramatic improvements in glucose. Many of these people are off of their medications. People with sleep apnea have marked improvements. Other health problems related to weight, like blood pressure and urinary incontinence, these get much better. And there's, as I showed you, lower mortality. But it has some risk. There's risk you might die from the surgery. That risk is 0.6%, which is similar to a gallbladder operation. This is safer than a hip replacement. So modern gastric bypass surgeries are, they're big time surgeries, general anesthesia and recovery stuff, but it's not like a heart operation or something like that. People do have complications. Some need rehospitalization. People need vitamin supplementation and monitoring for the rest of their life. And that can be a problem. Some people have very difficult to treat iron deficiency anemia or vitamin D deficiency. They can get osteoporosis. They have excess skin to deal with. They have surprising psychological issues. I see people, I had this one woman I saw, she lost weight and she just was miserable. And she just says, these men who treated me like crap for years are like hitting on me now. It makes me so angry I could punch him in the nose. It's, marriages break up, people start drinking alcohol. I'm trying to give you a balanced view. There's dramatic benefits to these, dramatic health benefits, but the reality for people's lives is often complicated. I'm done. I finished at the top of the hour. I'm sorry to talk 6 minutes. I can answer questions.
Yes.
We have some questions.
Anybody question in the room here?
Okay.
Great, you're getting to be shy. Maybe it wasn't interesting enough. I'll just go. A person becomes efficient at a certain exercise, they're running. Does this mean they run further, faster in order to burn the same amount of calories? They burn, yeah, good. You're doing the math. You're just like the math. That's a medical student question there. Yeah, so the answer is if you're more efficient and you're breathing fewer calories per mile because you're efficient, you would have to run harder or longer or faster. I think what happens is people who train, they actually start running faster because they are expending the same energy. It's like your body knows that. Let's see what we got. Do people who suffer from obesity have a lower basal rate? No, there's no evidence for that. I didn't show you the study because it's so demoralizing. They took a group of people who said, I test my metabolism, I got to have a metabolic problem. And they said, great, we'll put you in a metabolic chamber, we'll measure your energy expenditure, we'll weigh and measure the food that you're eating, we'll figure this thing out. And so what they found was these folks said, I'm eating 600 calories a day. And they know these people are watching. And they see and measure their food. They say, I'm eating 600 calories a day. And in the chamber, they say they're burning 3,000 calories a day. And they're eating 3,000 calories a day, but they think they're eating 600 calories a day. Now, when you see that, you go, those people are dumb or something like that. No, that's the lesion. Their brain doesn't know what they're eating. I think that's the problem is their biology. What they're saying is, I'm trying to eat less. I'm really trying to eat less. I'm trying as hard as I can. But the regulatory system is really powerful. I'm sorry. I have a lovely picture of you as well. You got other questions there?
I do. Let's see. Here you go.
I'm sorry. That's where life's.
Sure. This is really just a funny. How accurate are your eye watches? And
I'm not sure what that is.
It's me.
how accurate are your eye watches or all these other apparatuses?
Yeah, great.
They
So
tell
the
you-
question has to do generally with self-monitoring and self-monitoring of physical activity. There's a wide range of devices for monitoring physical activity, and they are okay, not great. The watch is not particularly great. It does some general things. It says you're walking, but in terms of the actual number of steps, the distance thing is okay because it's GPS. That's good. So it's okay. The problem is a lot of people always want to buy something. Actually, the guy I saw today, he was like, "This is I'm going to buy this and then my weight will go down." It's this consumer environment. We think if we buy a device, the weight will go down. I will exercise and buy. There's randomized trials that show giving people a device to measure their activity does not change their weight. Yeah, I think I use one myself. I encourage my patients to use them. with the understanding that the evidence in favor of that is not strong.
Can I ask one more?
Yeah, please.
Muscle mass. As it figures into your BMI.
Yeah, it's really important. The question was muscle mass and BMI. So BMI of 30, Arnold Schwarzenegger had a BMI of 30, but his waist circumference was like 24 or something like that. So he's all muscle. So waist circumference adds to our assessment because it's not just weight, it's central adiposity that it has adverse health consequences. So in a BMI of 25 to 35, it's recommended we do a waist circumference and there are cut points for that. So you're right, somebody could have a high BMI and have a lot of muscle mass and body composition. There are some things, bioelectrical impedance can measure percent fat. Problem is we don't have great numbers for what percent body fat is harmful. And also fat in the lower body, like women tend to have adipose tissue in their hips and thighs, men tend to get it in their belly. Fat in the lower body is not particularly harmful. It's fat in the belly that's harmful. So percent body fat isn't perfect either. The other part of this is as we get older, we tend to lose lean body mass. And the health effects are probably not only related to fat mass, but to the balance between fat mass and lean body mass. So people who have sarcopenic obesity, meaning low lean mass and high fat mass, they have the worst health risk. There are people who are 70 years old whose BMI is 25, but they have a high percent body fat because they don't have any lean body mass. So I think lean body mass is really important. And I worry with these new drugs that where people are losing weight, but they're losing lean body mass. Is that good for them or not good for them? That's why I think lifestyle for these bigger weight losses isn't focusing on getting more weight loss. It's making sure you get a good diet, like you're eating good food and that you're physically active enough so you're maintaining lean body mass. Other questions? They want to get, yeah, you got a question, I can see.
Fructose has been available to people in the environment forever. And now that we're adding it to food, it causes problems. Do we have any idea why?
Yeah, great. He said fructose has been available in the environment for millions of years. Why is it such a problem now? I think the answer is dose. You know, for you to get fructose 1,000 years ago here in Denver, you know, maybe in August you get some peaches in Palisade. Wait, they didn't have peach juice then. It was in the environment, but it wasn't present in high concentrations. You know, if this was a regular Coke and I had 5 of these a day, I mean, that's an amount of fructose you just never get anywhere. And it's in processed foods all the time. So I think in the old days, I would do diabetes. We'd encourage people to eat fructose because it's not glucose. So they'd measure their glucose and it wasn't high. Yeah, but it did other things. So I think we don't know, but I think fructose has uniquely harmful effects because of the dose. Let them go. Top one. With people using the diabetic medications to lose weight, and I have seen it working, when they stop, I assume they go back to gaining weight. It cannot be the miracle drug many are saying. Yeah, so exactly. The medicine only works as long as you take it. But that doesn't mean it's not a miracle drug. I think statins are a miracle drug and you have to take them the rest of your life. Blood pressure medicines are miracle drugs, you take them the rest of your life. These are chronic metabolic diseases. The assumption that it should work with a short-term fix you for the rest of your life, it doesn't fit with the biology. That's why I think the biology is so important to understand. Thank you for hanging with me so late on this night. It's nice to see you guys at home. Thank you for joining us too.